So our last activity is afternoon report, and Hendrik will be presenting. So Hendrik, you have the floor.
All right. I'm presenting a case today that I saw on ID consults at Sloan. Thank you, Anga. Let's start with the case. So it's a 56-year-old woman with B-cell ALL, status post T-cell depleted peripheral stem cell transplant 1.5 years prior. She unfortunately had a relapse 8 months prior. Status post multiple lines of treatment, also status post MDR Klebsiella bacteremia. She was admitted for hematemesis and hematoschizia in the setting of severe thrombocytopenia. She was found to be febrile on admission to 39.4 Celsius without O2 requirements. She was hypertensive and was admitted to the ICU, but she did not require vasopressor support. The chest X-ray showed opacities, and she was treated with meropenem for 5 days for neutropenic fever and a possible pneumonia. And EGD was deferred at that point due to thrombocytopenia and neutropenia. The bleeding stopped spontaneously. When seen by us on the 11th of hospitalization, the patient complained of mid-sternal chest pain and left upper quadrant abdominal pain, worse with inspiration. She endorsed cough with clear sputum production that had been going on for a while, she said, but was worse over the last week. And she denied shortness of breath, chills, further bleeding, nausea, vomiting, diarrhea, no headaches or any skin lesions. Her cancer history is complex, as you can imagine, at Sloan. She was diagnosed with B-ALL in 2019. She received hyperSIVA, which is a combination of cyclophosphamide, vincristine, adriamycin, and dexamethasone. The oncologists here, please correct me if I'm wrong. It was followed by blinatumomab, which is basically a T-cell engager that depletes CD19 positive cells. After that, she received her peripheral stem cell transplant. Unfortunately, she relapsed 7 months later. Again, got a course of blinatumomab. She had persistent disease, thus received a mini CVD, which is kind of a altered hyperSIVA protocol. She received inotuzumab ozogamicin, which is a CD22 antibody, which is fused with a cytotoxin. She received intrathecal methotrexate, was followed by another cycle of the same. Unfortunately, her disease progressed further. She received a menin inhibitor, which is basically an inhibitor of fusion protein. Due to progressive disease, she had to be started though on high doses of prednisone, and on disadmission was then started on venetoclax, which is a BCL2 fusion, BCL2 inhibitor, and it is inducing apoptosis in the tumor cells. That's the idea of this drug. Otherwise, her past medical history only was significant for Bell's palsy. In the 90s, she had an appendectomy in childhood, a lipoma was removed. Her family history was significant for a father that had chronic leukemia and a mother who died in the 80s and had dementia. Social history was significant for her being a former smoker. She drank alcohol socially and did not take any illicit drugs. She worked as an independent film director. She was born in Sweden and then moved to upstate New York, where she lived now with her husband, was an avid gardener. She had a dog, and she denied any recent travels, no known TB exposures. She had a pseudo allergy to levofloxacin and latex allergy. Medication-wise, she was on allopurinol and pulsodiol to prevent tumor lysis syndrome. She was on folic acid, on loratadine, and the venetoclax, as well as prednisolone, prednisone 100 milligrams daily, and that for over 6 weeks already. Current antimicrobials included cefixime, which she was transitioned to again for prophylactic reasons, after receiving the course of meropenem for her pneumonia for 5 days, she was started on micafungin, also for prophylaxis. Usually these patients are on an azole, such as posaconazole, prophylactically, which was in this case not given at home due to interaction with the menin inhibitor. And prophylactically, she was on atovaquone, PCP for prophylaxis, and on valacyclovir. On exam, the day that she was seen, she was afebrile. She had a stable blood pressure. She was studied tachycardic to 104, and she required 2 liters of oxygen now, instead of 97%. On exam, she was a middle-aged woman, no acute distress, no jaundice, no rashes. She had no conjunctival injections. She had a dry mouth, but otherwise no ulcers. Lungs were clear. Cardiac sound just was significant for tachycardia. She had a distended abdomen and a tenderness to palpation in the left upper quadrant. Her extremities showed pitting edema bilaterally. The lines look good. The PICC line did not show any signs of infection, and she was ANO times 3.
I think there's just one question in the chat. What Ariella is asking, what was the change in her clinical status that prompted the primary team to consult ID on day 11?
Yeah, I'll come to that finding in a little bit. On day 11, the same day, basically, labs showed a white count of 1, a absolute neutrophil count of 0, hemoglobin of 9.2, and platelets of 27. Chemistry looks pretty good, and the albumin was 2.4, so low. Due to the chest pain troponin was obtained, which was negative, and the EKG showed only sinus tachycardia. So this is the chest X-ray that was obtained on day 2. She just had this small minimal effusion on the left side, atelectasis, and minimal opacities. And on day 10, she was found to have worsening bilateral opacities, foremost on the left side. And the clinical change that prompted that X-ray was really the worsening cough with sputum, the left upper quadrant abdominal pain, right, and then the oxygen requirement. And anybody who wants to give a problem representation, it's a little bit of a complex case, but anybody wants to give it a shot.
Another question, Matt Alexander is asking, how old is the PICC line?
The PICC line was about 3 weeks old.
Okay. And any other questions about all the information we've reviewed? My question, I had a question. So why, this patient achieved meropenem for this presumed pneumonia and neutropenia. Any reason why the patient didn't get VANC? Because this is like a radiologically documented pneumonia in a patient with febrile neutropenia, so VANC coverage. Yeah, the team had not given VANC before we saw the patient. Usually it would, it would be part of the antibiotic regimen. The patient had this prior MDR Klebsiella, so they were covering with meropenem, but unclear why vancomycin was not given initially. Yeah. Anybody have any more questions about any of the data, history, physical, labs? Any, if any questions about the oncological history? Maybe let's go back to the labs.
Hendrik, the SpO2 was normal, right?
The SpO2 was normal on 2 liters. So she sat at about 89% without oxygen.
Mhm. But that was like a new oxygen requirement, or she was on oxygen during the...
So there was a new oxygen requirement.
So this is a complicated.
VBG, right?
Sorry?
We don't have VBG, right?
At that point, we did not have a VBG.
Okay.
And Matt's asking anything on the blood cultures?
Blood cultures were negative at this point.
It's a complicated case, a lot going on, like a lot of the patients at Sloan. So I think it's best if we just go ahead and summarize and give you the problem representation.
Yeah, I can do it. So we have a middle-aged immunocompromised female with BALL, status post stem cell transplant, and multiple lines of therapy, initially admitted to the ICU for pneumonia, neutropenic fever, and gastrointestinal bleed. Now with worsening cough, pleuritic chest, and abdominal pain, she was found to have a new oxygen requirement and worsening pulmonary opacities on chest imaging. The question of the cultures was already asked. So microbiology-wise, in the first 10 days, blood cultures were negative 3 times, and urine culture which was negative on day 12. Due to the worsening condition of the patient, the respiratory viral panel was %, which resulted negative. MSRE of the NARES was negative as well, and S pneumonia antigen was negative, as well as Legionella, and SARS-CoV-2 also was negative. Otherwise, prior to that, a TTE had been done on day 6. The EF was 67%, and without vegetations and no pericardial effusion. Any other imaging you would like to get at this point? Let me check the chat.
Ariella asks for a CT chest. Fair. I actually had a question about the initial stay as well. So did the patient respond at all to the meropenem, or did the patient, just continue to deteriorate while the patient was in the ICU, or was there some improvement and then you had new?
Yes. So the patient initially improved, right, and this is when meropenem was de-escalated back to cefuroxime, which she actually got. Her hypotension improved, right? And initially she actually did not have oxygen requirements. So initially improved and then got worse, right? The question is fungal cultures were sent. So initially there were no fungal cultures sent at that point, not yet. So the CT chest is a very good idea, I think, and it was obtained. And they also got a CT abdomen because of the abdominal pain that the patient had. And it shows these lesions here, right? Let's go ahead. As bilateral dense opacities, right? A moderate pleural effusion on the left and a small one on the right. And on the abdominal imaging, we see moderate ascites. And in the spleen, we see these wedge-shaped infarcts as well. Otherwise, a thoracocentesis was done of the pleural effusion, the moderate, the bigger one. It showed red turbid fluid, about 128 nucleated cells, more with lymphocytic predominance, 74%, pH was 7.33, LDH 165. We had an exudate, and the gram stain and culture here resulted negative. A CT head was obtained on day 12. The patient had developed some vague headaches, and it showed this lesion here, this hyperdense lesion in the parietal lobe. All right, what would be the differential diagnosis at this point in this immunocompromised patient, thinking of lung and brain lesions? In which further testing would you like to do?
Anybody want to give any potential causes of lung and brain lesions, or anything you suspect in this patient? This patient who's had a very complicated oncological history, but profoundly immunosuppressed, who comes with initially neutropenic fever and pneumonia, gets treated with antibiotics, improves, but then has worsening. Frida thinks endocarditis, TEE. Yeah, that's a possibility. Culture was negative, but it could always be culture negative endocarditis. So that's a good suggestion. Anything else? Anything else which could cause lesions?
I mean, the drainage from the effusion was like the lymphocyte count was high, right? The neutrophil was the
Yes, 74%. That's correct.
Which is kind of against like most of the bacterial infection, except maybe TB or something more viral. Or
what else can cause that picture in pleural tap? So I think on the chat.
Yeah.
And and I agree that it definitely speaks against the bacterial infection. I see in the chat already invasive disseminated fungal infections, crypto, very good, excellent. Yeah, all good causes. We need
any more,
rule out disseminated infections. Fatma says, excellent. And also the TEE, good idea, and it was exactly discussed also at this point. The patient didn't get it, also because it was still thrombocytopenic, neutropenic, and so it was deferred at this point also. I can go ahead at this point with what we did next. If we have some very good ideas. So first, I would like to go over some differentials that were already mentioned also for concurrent brain and lung lesions in terms of ID pathologies. This overview here I have from a podcast called Febra podcast that I can highly recommend to everybody interested in ID. So causes can be bacterial, fungal, parasitic, and microbacterial. Bacterial causes can be endocardia, for example. Streptococcus aeruginosus often causes abscesses from the mouth, and Staph aureus, of course. Hypervirulent Klebsiella pneumonia was found to cause concurrent brain and lung lesion, as well as Lemierre syndrome, which is an anaerobic infection of Fusobacterium from the throat of younger people, actually, that leads to an infectious thrombophlebitis of the internal jugular vein, and then can disseminate. As mentioned, embolic phenomenon from endocarditis, always. Fungal infections were mentioned as well, and molds, Aspergillus and mucormycosis, for example, are possibilities, or dimorphic fungi such as Cryptococcus, histoplasmosis, blastomycosis, or Coccidioides as well. Parasites such as Toxoplasma can do it, and TB always, also non-tuberculous mycobacteria can be a cause. So on day 12, a beta-D-glucan was sent in the serum, and it was strongly positive. Pneumocystis PCR was negative, as was histoplasma antigen. 3 days later, a Aspergillus galactomannan antigen resulted positive in the serum. At that point, it was proposed that the patient get a BAL, but she refused. Treatment had been started already, had been switched back again to meropenem at that point, and she was started on isavuconazole. The product is called isavuconazonium sulfate. You give a loading dose, and then she was started on Q24 hours for suspected invasive aspergillosis, which was then also at least partly confirmed by these studies. Unfortunately, on day 19, the CT chest showed a worsening consolidation, foremost in the left lung now, but in the heart, the pleura as well, and a new pericardial effusion as well. After some contemplation, she did agree to the BAL, to the bronchoscopy. A washout was done in the lymph node biopsy, and the surgical pathology of the lymph node showed angioinvasive, tissue-invasive fungal hyphae. With the morphology, there was a just of zygomycete species associated with marked tissue necrosis. The Aspergillus galactomannan antigen was also strongly positive in the BAL. Bacterial cultures were negative, fungal cultures were negative. Also AFB was negative, and mycobacterial PCR as well. On day 23, she was started on liposomal amphotericin B. It was added to the current therapy because of the diagnosis of mucormycosis, which was suggested by the zygomycetes that were found on pathology. On day 23, she had an IRT call for AFib with RVR. She was admitted to the ICU, and the RVR was controlled with amiodarone. On day 25, the decision was made to transition her to comfort care due to the progression of her disease and also the advanced state of her underlying ALL. The patient expired the same day due to hypoxia and the cardiac arrest. With this case, it shows basically a co-infection of aspergillosis and mucor. I first want to talk a little bit about invasive aspergillosis, and then if we have the time, which I think we will have, to quickly go over mucormycosis as well. So Aspergillus is a filamentous fungal mold, which is endemic worldwide. It's found in soil and decomposing matter. It's transmitted via spores. The most common Aspergillus species in humans is Aspergillus fumigatus, followed by Flavus, Aspergillus niger, and Aspergillus terreus. The disease progresses over tissue planes. It invades the vasculature. It leads to infarctions and to tissue necrosis. Risk factors include prolonged neutropenia, hematological malignancies, chronic granulomatous disease, graft-versus-host disease, and corticosteroid use. We can see that our patient already had 3 of those. The mortality may exceed 60% in high-risk patients, such as patients with allogeneic stem cell transplant. The manifestation of invasive aspergillosis are mostly of the respiratory tract, commonly involves pneumonias, trachobronchitis, and sinusitis. With pneumonia and with trachobronchitis, you will have fever, cough, can cause dyspnea, pleurisy, chest pain, and hemoptysis. Sinusitis can present with facial swelling, pain, epistaxis, proptosis, can show with cranial nerve abnormalities. So purulent discharge also of the nose and nasal obstructions. CNS manifestations can cause fever, seizures, focal neurologic deficits, and autonomic status and headaches. The IDSA has recommendations for diagnosis. The last ones are from 2016. The gold standard is a pathologic cytologic examination of cultures and tissue. Typically, we see these branching hyphae that are seen under microscopy. Galactomannan testing is recommended in serum and BAL samples, in particular in patients that have hematologic malignancies and a status post stem cell transplant. In patients that receive mold-active antifungal therapy, actually, the BAL should be used. Serum is not recommended. This is more for screening also of patients. And galactomannan is not recommended for screening solid organ transplant patients and those with chronic granulomatous disease. Although it's not specific for Aspergillus, the beta-D-glucan assay should be sent to diagnose the diagnostic process of invasive aspergillosis, especially in high-risk patients. CT chest should be obtained if there's a suspicion of invasive pulmonary aspergillosis, as well as a bronchoscopy and BAL, as already mentioned. Quick word about the galactomannan assay and the beta-D-glucan. So the galactomannan is a polysaccharide of Aspergillus species, and it's when Aspergillus has its hyphal growth, it sheds the cell wall, and so this is what we can detect. The FDA-approved ELISA in serum and BAL to know there are false positives and false negatives. False positives can occur in, for example, Fusarium species and Penicillium species, and in histoplasma. Also, in older formulations of sosin, IV sosin, can cause it. The other beta-lactams not, as well as IVIG. 100 days following transplant and also mucositis can have false positive results. During mucositis, we have a translocation from the mouth often. False negatives can occur in antifungal treatment, as mentioned, and with Aspergillus antibodies. Beta-glucan is a common cell wall component, really, and it's in multiple fungal species. So it has, sensitivity of only 77% for invasive aspergillosis, and the specificity for any fungal infection, really, in an immunocompromised host is 85%. Diagnostic criteria are also from basically in imaging. On CT chest, in 90% we have nodules. The halo sign is seen in 60%. The halo sign you see here on the right side, which is basically this hyperdense nodule with a less hyperdense, more ground glass surrounding, which reflects the invasion of the lungs by the fungus. You can have cavitary lesions in 20 to 60%, and the air crescent sign, which shows really as crescent-shaped, absorptions in the periphery of the nodules, which is a sign of a resolving Aspergillus lesion. There are criteria by the Europeans for diagnosis. You can differentiate between proven, probable, and possible invasive pulmonary aspergillosis. So you have it proven if you have a sterile sample in a biopsy with evidence of hyphae and tissue damage, for example, necrosis, right? Or if this culture becomes positive. You have a probable diagnosis when you have, different factors. It becomes a little bit more complicated. We have host factors, clinical criteria, and mycological criteria. So host factors, as we already basically mentioned, and a lot of our factors are present in our patient, is neutropenia, right, over more than 10 days. Somebody that has a stem cell transplant, for example, prolonged courses of corticosteroids, 0.3 mg per kg, basically per day, which in a 70 kilogram patient is just 20 milligrams, right? Not so much, for over 3 weeks. And other treatments with, T-cell suppressants, TNF-alpha blockers for in the last 30 days, 90 days every 3 months, and severe immunodeficiency. Those are all criteria that the host brings. Clinical criteria, mostly radiological. Any one of those, like an air crescent sign, a cavity, or a dense, basically nodule with or without air crescent would count. Mycological criteria, basically everything that shows, the fungus directly or indirectly in a non-sterile sample, for example, sputum sample or washout. Can be, the hyphal elements themselves. If you have Aspergillus positive in that culture, if you have galactomannan positive or beta-glucan. You have possible invasive pulmonary aspergillosis if you have just a host factor and a clinical criterion, radiological one, but not a mycological one. So our patient would fall in the probable IPA category here. Treatment of invasive aspergillosis is first line with voriconazole. That has to be given IV, and once the patient is clinically stabilized, it can be transitioned to PO voriconazole. The voriconazole levels should be measured, which is always kind of a pain, because the levels are difficult to maintain stable. So 0.5 is kind of the lower range, and then levels over 3 you have hepatotoxicity, over 4 you have neurotoxicity. Voriconazole is a drug with a lot of side effects. Alternative first-line regimens are isavuconazonium sulfate, isavuconazole that was given in our patient, and liposomal amphotericin B as well, that can be changed then to voriconazole or itraconazole. Salvage regimens, if that doesn't work, are caspofungin, micafungin, posaconazole. If the medical treatment fails, then a thoracic surgery eval should be obtained. All right. So the other infection that we found was mucormycosis. I won't spend too much time on this one, but just quickly, it's caused by Rhizopus species mucor Lichthymia cunninghamella. Also, it's transmitted through spores and decaying matter. And the pathogenesis is also due to invasion of blood vessels, leading to hemorrhage, thrombosis, hematogenous spread. Risk factors are pretty similar to invasive aspergillosis. The exception is diabetes has a huge role here as well. Then deferoxamine treatment and iron overload. Signs and symptoms also pretty similar: shortness of breath and pleuritic chest pain. Due to angioinvasion, it can cause hemoptysis, and the bronchial lesions can lead to obstructions. And otherwise, it can have symptoms of concurrent rhinosinusitis. And the diagnosis, also here, gold standard is to get culture histopathology. The microscopy is a little bit different. It shows broad non-septate hyphae with right angle branching. This is more important for the ID boards than I think for the internal medicine boards. CT chest shows also mass-like lesions. It has, interestingly, a reverse Pareto sign, which is basically bronchial opacities in the center, and then a dense lesion around it. Also here we differentiate between proven, probable, and possible. Proven also sterile site with hyphae and tissue damage. Probable has host clinical and mycological criteria as well. And the possible infection has a host factor and clinical criteria, but no mycological criteria. The management of mucormycosis is via liposomal amphotericin B, what our patient also received after the zygomycete species were detected. Posaconazole or isavuconazole can be used as maintenance salvage therapy. If possible, we'd like to reverse the underlying condition, such as diabetes, for example, which is a common cause. And sometimes surgical evaluation is necessary. The mortality is very high, up to 76%, really. All right, some take-home points. The infectious causes of concurrent lung and brain lesions can be bacterial, fungal, and parasitic in origin. The risk factors for invasive aspergillosis are prolonged neutropenia, hematological malignancy, chronic granulomatous disease, graft-versus-host disease, and corticosteroid use. The treatment of invasive aspergillosis is with voriconazole, with isavuconazole as an alternative, and liposomal amphotericin B. A co-infection with other molds is not common, but it's possible in severely immunocompromised patients, such as in our patient. The treatment of mucormycosis would be with liposomal amphotericin B, and then followed by isavuconazole or posaconazole as maintenance therapy. And thank you. These are some of my references, and any questions I can answer.
Thank you, Hendrik. Unfortunate for the patient, but important take-home points would also be in a patient with febrile neutropenia who's been on antibiotics. Any deterioration should raise suspicion for fungal etiology. And then you should also know that, if there's concurrent brain and lung lesions, then you should have a schema for your differential. As a lot of you pointed out, endocarditis is something which is common, and you should definitely keep that in your differential and then think about other possibilities.
Thank you so much, Hendrik, for this nice presentation. It's a very nice case. Unfortunate, but as Angat said, it raises those kind of differentials that we need to think about when we have immunocompromised patients. So for this patient, do you think there was a delay on initiating the antifungal treatment, given that she was in the hospital for 11 days? This is one question. My second question, why did you go with the alternative to voriconazole, and you didn't initiate the treatment with voriconazole, and why you didn't get another agent? As you said, if it didn't work, we can go to another, add another therapy.
Right. Right.
Yeah.
I think both very good questions. First question, so to begin with, the patient should have been optimally before admission on a prophylaxis. Posaconazole is often used, right? Which the patient was not on, that already, put her at higher risk, right? But there was some, interaction with the menin inhibitor that she was on, and this was the reason why. And then she was admitted, and then IV micafungin was given, which has less of a side effect, right? But that was all prophylactically, really. I think in the beginning, you didn't have a lot of lung findings. The suspicion was, okay, neutropenic fever, and then a possible bacterial pneumonia, and so she was started. And then with the clinical worsening, right, that happened with the hypoxia, worsening symptoms also, and these new findings, then she was started, right, and that was basically day 11. Some providers might have started her earlier already on the therapy when she was not improving, right? The other question was it was really a contentious point, like why isavuconazole and not voriconazole, especially as we know that, or at least we have more experience with voriconazole with brain lesions, right? Often, at least it's believed that voriconazole penetrates better into the CNS. Right? However, some providers will prefer isavuconazole in this case because of the side effects profile. But other providers would have chosen voriconazole, and it was definitely a contentious point. We have a little bit of time left, and I have actually, I was like, I don't go in too much detail about that, because it's a little bit specific, but just as an outline, like isavuconazole versus voriconazole. The decision was partly based on this trial, right? The Europeans did a trial where they compared isavuconazole and voriconazole for in general filamentous fungi, including Aspergillus. It was basically randomized, double-blind, multi-center trial, and they compared isavuconazole with voriconazole. Patients were over 18, and they had a proven, probable, or possible mold infection. However, patients were excluded that had hepatic dysfunction, renal failure. They were on a mold active agent or had AIDS, right? You had like 500 patients that were randomized, and you gave them basically isavuconazole, voriconazole. Endpoints were the non-inferiority of isavuconazole and the all-cause mortality at day 42 was the primary endpoint, intention to treat analysis. Second endpoints were the same at day 84, and then looking at clinical, mycological, radiological criteria, and there's the side effects. I won't go over these, those are just the baseline demographics of a bit more males. Otherwise, mostly they were Aspergillus species, right? Fumigatus flavus were the most. Let's jump over that. So here you saw basically the survival was about the same at day 84, isavuconazole, voriconazole, and however, the safety endpoint was better with isavuconazole, where you had less hepatobiliary disorders, eye disorders, right? Skin subcutaneous disorders, very common with voriconazole. The serious events were the same. Some more patients discontinued the drug, either voriconazole rather than the isavuconazole. However, it's limited generalizability, right? For example, as an outpatient, it was an antifungal prophylaxis. These partly so that would have been excluded. So partly, thinking about the side effects of voriconazole, the isavuconazole was chosen, but I would say many providers would have chosen voriconazole. Yes.
And I have one other question. Is there any precautions that we have to tell our patients who are immunocompromised to take, whether with gardening, birds exposure, those kind of stuff, or even like travel?
Right. Definitely. And all these, so already in a pre-transplant evaluation, right? They would have to be seen, and you have to discuss these issues with them. And some are, for example, mold exposure, right? If your patient is a plumber, right, and has a lot of mold exposure, then you would have to tell him, you might not be able to go back to your work, right? Then the bird is also a very good point. Sometimes you have to get rid of the pets. I think most people actually don't do that, but at least, don't, have somebody else clean out the bird cage, for example, right? Things like that, where the cats, of course, the toxoplasmosis, it's not, not every patient gets screened for toxoplasmosis, but most in the end do, and don't basically empty the litter box of the cat, right? This is also something we have to tell the patients. And then, travel wise, they're mostly the same, but some things like spelunking you couldn't do, right? For example, you tell the patients not to do. But yeah, so this is all part of the pre-transplant evaluation, and patients have to know about these things. And unfortunately, sometimes we cannot prevent these infections from happening. So
Yeah, thank you.
Yeah, thank you.
Thank you. Any more questions for Hendrik? If not, we can call it a day. Thank you everybody for joining, and thank you, Hendrik, for a great presentation.
Did everybody sign up for the end of the year party, the graduation party? All right, the deadline is by the 2nd. So sign up or forever hold your peace.
Actually, if we have some time, we can also do the well-being survey. So we have enough time for everybody to complete it. I'm going to post the link in the chat. And then we can take the last 10 minutes to complete the survey. Okay, link is in the chat, please. It'll take less than 10 minutes, and you have the chance to win an iPad, AirPods Pro, or travel mugs from Sinai as a part of the raffle. And then once you're done with the survey, we can all sign off. So thank you everybody.